Hey, good afternoon, everybody. This is John, of course. Welcome to week 5. So we are officially through the midway point, and it's all downhill from here. Theoretically, of course, the meat of our assignments and milestone assignments are coming up. We had our first milestone assignment last week, and you should have received my feedback. Of course, if you have any questions about any of my feedback, I'm always open to talk and chat. Of course, my main objective, as I've said before, is for you to get value out of this class. So please, if there are questions hanging out there, I would love for you to reach out and we can talk through anything. So before we get to, I want to talk a little bit today about the economics of healthcare. We don't necessarily have a discussion question on this. It is to a certain extent covered in your text, but the title of this class is healthcare. What is it? Healthcare legal and ethical considerations, and so the economics of healthcare is certainly an important part of that, and I'll get to that in a moment. But I want to cover first two things. First, talk about the discussion question from this last week, and then a little bit on just general insight, feedback on the first milestone assignment on the iTroldy case. So first, with respect to the discussion question, good job. I appreciate the insights. I think the analysis was good. I will definitely just continue emphasizing throughout each of our assignments and our discussion questions is to utilize that Iraq form of legal analysis. And I guarantee you'll get sick of me hearing me say this, but it's a huge part of this class. And so essentially what I'm trying to avoid is comments or insight that start with, I feel that ... So I feel that this was a breach because you shouldn't tell your supervisor this, or you shouldn't be looking at medical records, even if it was inadvertent. So, legal analysis, unfortunately, has nothing to do with feelings. It's more of, okay, what is the issue? What is the rule? In the case of our discussion question, the rule was found in the definition of breach. Was it a breach? Well, what is a breach? A breach is defined to include a variety of factors to consider and even some exceptions. So those are an important part of the analysis. And one of those exceptions potentially applied to the first scenario in the discussion question. But you know that by applying the facts to the rule. And then you come out with your conclusion. So that was important for that discussion question. It's also important for purposes of the iTroldy assignment. So we did the first draft on the legal component. We're going to do the ethical component later on. But on the legal side, we talk about what are the legal components. If you look at the rubric section, what are the legal components? What are the rules associated with those components? So for me, legal components, okay, so what legal component applies to Dr. Ricketson? Well, certainly, medical negligence is the big one. So there's not just one rule that applies to medical negligence, because it's comprised of 4 elements as we've discussed. So there are 4 different rules. And so you got to apply, what are those rules? So, okay, first issue is whether a duty existed. The rule for when a duty exists is when that physician-patient relationship is formed. Give me the fact that in the case that shows that, apply it to the rule, come out with your conclusion. Element 2, was there a breach of that duty? Well, what's the rule? What are the facts? Apply those to the rule, conclusion, and causation, and damages, and so on. So, and then what legal components apply to the hospital? Those are all important parts that need to be included in that section. For the policies, for the malpractice policies, what are the policies the hospital had in place to address the issues? There's one in particular in the opinion that should be included in that section. So remember that causes, like legal causes of action, like medical negligence, is not a policy. Those aren't policies. Those are legal claims. Policies are a little bit different. So just, I'll continue emphasizing the importance of that method of legal analysis throughout this course, and it's definitely going to be an important part in this milestone assignment. So keep working on that, and you guys are doing great, and let me know if you have any questions on that. So this week I just want to talk briefly about the economics of healthcare. It's always a big topic of discussion, particularly in an election year, which we are in. So we've heard all kinds of different healthcare proposals. We've heard a lot on healthcare, especially lately with the current pandemic that we're in. How to pay for healthcare, how to deliver healthcare, what's the most efficient way to do it, what's the most economic way to do it, what is the best way to do it from a quality perspective. These are all highly debated topics, and unfortunately somewhat political topics. A lot of times what we believe is driven by our politics, but I think there are a variety of ways to do it efficiently or economically, and from a high quality perspective. So the question that I want to talk about, just kind of talk through, is a little bit about how we pay for healthcare, the business of healthcare, fraud and abuse in healthcare. This is sort of my wheelhouse. This is what I deal with mostly on a day-to-day basis, is sort of just this business side of healthcare and fraud and abuse type issues. So, there are really two main components to paying healthcare. One is the private payers or insurance that we get from our employer group health plan through our employer. And there are a variety of different employer group health plans. There's PPOs, as we know, HMOs, EPOs. There are self-funded plans. So if you work for a large corporation, many times, more times than not, they will self-fund their insurance, and just hire a company as a third-party administrator to adjudicate the claim, pay the claims, distribute benefit material, and things like that. And then there are what we call individual exchange plans. That's a product of the Affordable Care Act, where you can, if you are self-employed, you can go and go onto your state exchange and purchase healthcare insurance. So that's another option that was created back in about 10 years ago, just over 10 years ago. And then there are government programs. So we're very familiar with Medicare, right? So you have to meet certain criteria in order to qualify for Medicare. You have to be at least 65 years old, or you have to be disabled, or you have to have a diagnosis of end-stage renal disease or ALS. So those are certain criteria that will qualify you for Medicare. Medicare pays 80% of what they have determined to be their fee schedule. So the other 20% is either paid by you as the program beneficiary, or you go out and get other insurance. So there are Medigap insurance products. There are other different products out there that are designed to fill this, this what's called the Medicare donut hole that needs to be covered, whether by the patient or another insurance. And you figure, if Medicare pays 80% of a very large, high cost procedure, 20% is still a significant amount to pay out of pocket. So a lot of Medicare beneficiaries do get other coverage as well. There's Medicare Advantage, which is a Medicare product, but it's administered through your Blue Cross or Cigna. They have Medicare Advantage plans. There are a lot of benefits to that. There are a lot of changes actually to the Medicare Advantage program coming up this coming year. And then you've got Medicaid, which is a state federal combined program that's designed to cover, as we know, low-income folks, and there's been a lot of discussion over the last few years about Medicaid expansion, last several years about Medicaid expansion and who to cover, who not to cover, the cost, the federal contribution for the Medicaid programs, the state contribution. There's just a lot going on, and Medicaid is a huge program. And so one thing that we've seen a lot over the last several years is the increase in because you have these very high cost programs, and the cost of healthcare in this state is very, very high. So you've seen a lot of emphasis on value-based healthcare, integrated healthcare, ACOs, accountable care organizations, a product of the Affordable Care Act. And so there are a lot of different hybrid types of ACOs where providers get paid based on value, based on quality, as opposed to this fee-for-service concept. So instead of getting paid every time you do something, which just theoretically incentivizes you to do that thing more often because you get paid more, value-based care contemplates a lot of different types of providers, hospitals, physicians, specialists, that come together to take care of a certain set population of patients, and they're all responsible for the care of that patient and for driving the cost of care down for those patients. And if they do so, they get incentivized. So that's the concept of accountable care organizations. It's really the concept of value-based care. I have many clients that do value-based care, or that are companies or healthcare software companies that are really targeting providers that give value-based care, because that's really the up and coming, and I really think that's the future of healthcare. So let's talk about the business of healthcare real quick. One thing I wanted to cover is something called the corporate practice of medicine doctrine. This is a conversation I had with a client the other day that was trying to, a guy who was not a physician, was trying to create a company that employed physicians to go out and provide services. Well, in some states that's okay, but in many states that's not okay, because that violates what's called the corporate practice of medicine doctrine, which essentially prohibits non-physicians or companies, non-professional companies, from employing doctors to provide medical services. And the idea behind that doctrine is that they don't want a non-physician to affect or impact or drive the medical judgment of the employee physician, right? So it seems to make sense from just sort of this hypothetical, theoretical standpoint. You wouldn't want Walmart, for example, telling an employee doctor to not give you a certain treatment or not give you a certain drug, prescribe a certain drug because the cost is too high. I mean, really, that decision should be left to the professional judgment of the physician. Now, there are pros and cons to the corporate practice medicine doctrine, and there are a lot of ways around it. So, but that's I'd say probably half the states adhere to some form of this corporate practice of medicine doctrine. And so my example of like you couldn't go to like a Kroger store wouldn't employ a doctor to provide care to customers, right? So the question you probably have is, well, I see these minute clinics in a Kroger store, and you have Walmart, who's really big into the healthcare game right now. So how does that doesn't make sense? Well, this is one of the ways around the corporate practice of medicine doctrine is essentially what a Kroger or a Walmart would do is get a physician to form a professional entity, right? So like a group practice, and then Walmart or Kroger, whoever, would essentially manage that practice, not employ it. It would be its own separate entity, but essentially manage it, get a management fee for their administrative services. And so that's how a lot of those are structured. Okay, so lastly, I just want to talk a little bit about fraud and abuse. So I do a lot of work with things like Stark Law. So if you're familiar with Stark Law, it applies to physicians, it applies to Medicare, and it's basically the anti-self-referral statute, federal statute, that says if you're a physician and you have a financial relationship with a healthcare entity, you can't refer patients for certain types of services to that entity. So by financial relationship, I mean the physician has a compensation arrangement, so like an employment agreement or independent contractor arrangement, or an ownership interest in it. So the physician, I mean, it makes sense to a certain extent that you don't want your physician just referring you to a lab, for example, or to go get diagnostic testing. Just to that single place, if the physician has an ownership interest in it, so therefore the physician is benefited by the referrals that he or she sends over to this imaging center. And the idea is it incentivizes more of these services. It may cloud the judgment of the referring physician. Now there are it only applies to certain types of health services. It only applies to the Medicare program. It only applies to physicians. And there are a lot of exceptions to it. So, but I just want to kind of give a quick overview. So a lot of people compare that, and a lot of times they go hand in hand, the Stark Law with the anti-kickback statute, which is also a federal law, which is actually a criminal law. Although there are civil monetary penalties, it's a criminal law that prohibits really giving anything of value, any remuneration, any payment, anything that would benefit the other party in exchange for patient referrals that receive services that are payable by a federal health care program. So I can't, I mean, it would be against the law, and it'd be a crime for me to go up to a physician and say, hey, if I refer these Medicare, Medicaid patients to you, will you give me a cut of what you get, of what you collect? I mean, that's a crime. So that's against the law, and it's against the law for me for offering that. And it's against the law for the doctor for accepting that offer. So it's a criminal penalty. It's a felony, 5 years in prison. A lot of civil monetary penalties that go along with that, and that kind of goes hand in hand with fee splitting. Fee splitting is more of a state law issue, but it's a lot of states prohibit fee splitting, which is essentially just what it sounds like is you split a fee for providing patient referrals. So those are a lot of the things that kind of go on. The OIG just came out, the Department of Health and Human Services Office of Inspector General, which governs and enforces the anti-kickback statute, not Stark. The Stark Law is enforced by CMS, but they do a lot. They do all kinds of healthcare fraud and abuse enforcement and auditing, and sanctions and penalties. And they just came out this last week saying that they recovered over $3 billion. So healthcare fraud and abuse enforcement is a big business for the government because there's a huge return on investment. So they recover over $3 billion on a budget of about $150 million. That's huge, which just means that enforcement keeps getting tighter and tighter and tighter because they just keep recovering more money. So which is always a problem for providers that either aren't familiar with the law or aren't really trying to do anything harmful. They just get caught up and sometimes get scrutiny from this type of enforcement. So anyways, that's all I had this week. Just want to give you some insight on that area, just in the name of being comprehensive in this class. So again, Iraq method of analysis. Remember the feedback that I've given you here and that I've written for you in your milestone assignment. And as always, let me know if you have any questions, and good luck with week 5. Hope you're all well. Have a great week.